They are 5 families, M1 and M5, and these have distinct distribution. And now we have drugs that can target specific muscarinic receptors. Okay, so an agonist for muscarinic receptors is muscarine, and that's where that name comes from. Okay, so they mimic the function of acetylcholine at the M receptors. And atropine is a classic antagonist of acetylcholine at muscarinic receptors. And when we shall talk about atropine poisoning, then we shall see that it totally opposes the functions of acetylcholine. Nicotinic receptors are there's nothing here that suggests that they're found in the brain. Okay, they're just found in the neuromuscular junction and autonomic ganglia and in the adrenal medulla. They're not G protein coupled receptors. They're ion channels, and they have 5 subunits. We shall see that. So there are 2 types of these nicotinic receptors. So this M denotes those ones found in the skeletal muscle, and this one denotes those ones found in the autonomic ganglia. So nicotine, nicotine is a common alkaloid found in tobacco. So this one is an agonist at neuromuscular junction. And tubocurarine, you've learned in pharmacognosy about tubocurarine. It's a poison that causes paralysis. And so this one is a classical antagonist of acetylcholine at nicotinic receptors. So this is another summary of where you find those things. It's good that you have this, at any point, because when you know this, then I think autonomic pharmacology becomes quite easy. Now, this is basically what you've been talking about, just to give you a visual feel of how these proteins look like. And if you can appreciate that there's transcellular, either ion channels or G protein coupled receptors. Of course, we know from pharmacology 1 how G protein coupled receptors work and how ion channels work. Okay. Now, let's talk about cholinomimetic agents. Now, these agents that mimic or do the function of acetylcholine when they bind to these specific receptors. Now, they are classified into several categories. First one is directly acting, so they basically act like acetylcholine. And they include acetylcholine itself and these related compounds that are choline esters. Then we have alkaloids. We've talked about muscarine, pilocarpine, and acetylcholine. I remember in physiology first year, these are things that we are familiar with. So these are directly acting. So make sure you know the differences between direct and those that act indirectly. So the indirectly acting cholinomimetic agents basically inhibit the metabolism of acetylcholine. It means acetylcholine will persist at the synaptic cleft or at the neuromuscular junction or whichever position it's being produced, such that it can exert its effects for a prolonged period of time. Now, so if you're told to classify indirectly acting anticholinesterases, there are these categories. They're either reversible or irreversible. Now, for the reversible ones, we have tertiary compounds, physostigmine and trypsin. And you should, part of your reading, read about the difference between these tertiary and quaternary, and which one can cross the blood-brain barrier. And we have quaternary compounds, neostigmine, pseudosigmine, trophonium. Now, these ones bind to acetylcholinesterase reversibly. It means the binding is not permanent, and any poisoning can be reversed. Any poisoning can be reversed. Now, this one is in contrast to the irreversible ones, for example, organophosphates. Now, we shall learn about organophosphate poisoning. Now, organophosphates are basically insecticides, and these insecticides are used to control mice and ticks, and in the house to control cockroaches. But they are also a common source of poisoning, and especially men. When you'll be going to hospital, you'll realize that men poison themselves quite a bit for reasons I don't know. And we shall learn about the signs and symptoms of organophosphate poisoning. You really need to know them, because as a pharmacist, in case of poisoning, you're the first person to be contacted. Now, so for organophosphates, what they usually do, they form a covalent bond with the acetylcholinesterase, and it means acetylcholine will act with, let me say, with impunity, because there's nothing to metabolize it, and you'll have serious symptoms, and it's a common cause of death. Okay, and for employees working in flower farms where they have to use organophosphates to control insects, they do develop a lot of organophosphate. And yes, and also for substances used to control things like bed bugs, yeah, they're all organophosphates. Then we have carbamates. These ones are not as risky, and they are not as irreversible. They are reversible, and these ones are not as risky as the organophosphates. So, and on top of this, read about I think, I don't know if I should give you notes, but read about pyrethrins. Where do you get pyrethrins from?
Pyrethrum.
From pyrethrum, yes. So pyrethrins also are, if you look at your can of doom or anything that you're using to control mosquitoes, they all contain pyrethrins and other compounds. Okay, so pyrethrins basically act as reversible anticholinesterases. So same thing, and poisoning management is basically not different from the one you'll get if you have organophosphate poisoning. Now, so we mentioned, now we'll go deeper into these compounds, and we said the cholinergic drugs are basically parasympathomimetics, and they mimic the action of acetylcholine. And in the heart, we talked about the distribution of the muscarinic receptors. The heart has an M2 receptor, so it will depress the SA node, will reduce the heart rate and the force of contraction, and it decrease conduction velocity. Basically, these are the vagus effects. Vagus stimulation leads to general slowing of the heart. Okay, And in the blood vessels, the relaxed vascular smooth muscle. And as we said, the parasympathetic nervous system will tend to oppose the functions of the sympathetic nervous system. So when you're relaxed, generally your the vasculature is relaxed so that your blood pressure is low. And it means now if you are scared, okay, if something has come up and you're scared, it means your vascular smooth muscle will contract because of release of acetylcholine, because of release of noradrenaline and adrenaline, and it means the sympathetic nervous will take over, okay, to make sure that you are ready to fight or to take off. Okay. Then the blood vessels are dilated, and also it means the blood vessels of the skin and they're also relaxed, and also those of the mucous membrane. So mucous membrane, it means the production of mucous membrane is ever in our GIT. So it means the normal functions of the GIT will go on when the parasympathetic nervous system is in action and the blood pressure is low. Now, on a smooth muscle, they'll increase the tone of all other non-vascular smooth muscles. And this is important because for digestion to happen, peristalsis has to occur. It means they are all, the things that happen without you noticing. So the peristalsis happens because of this M3, presence of M3. Now, also, because of M3, have you learned about H2 receptors? You learned about otacoids, right?
Yes.
We did otacoids. And remember when we talked about histamine binding to H2 receptors in the gastric parietal cells?
Mm-hmm.
And then there's something we talked about acetylcholine stimulation on the gastric parietal cell. Do you remember?
Yes.
Yes. Now we have drugs that actually bind to M3 receptors, and they're used to control excessive sweating and also to manage gastric acidity. So we have those molecules in the market now, in the Kenyan market. That's that. Now, for the urinary bladder, they contract the extrasum muscle, and it means in the urinary bladder, you need acetylcholine for you to void urine. And I said that's why anticholinergics will affect your urinary functions, and that's why one of the side effects of H1 receptor antagonists, because they have anticholinergic effect, is that they affect your ability to void urine normally. That's why we say they cause urinary hesitancy. In the bronchus, they cause contraction, and that's why if you have an asthma attack, and what happens when you have an asthma attack and you rush to hospital, or when you I'm sure you've been to hospital, and the first time somebody comes to hospital and they having an attack, what happens? What do those nurses do? Come on, you at the hospital? Not even once.
are given bronchodilators, or it can also be oxygenated.
Oxygenation?
It can be oxygenated when given oxygen therapy.
How is that bronchodilator delivered?
You are given injectable through the IV.
No.
Like you can be given aminophylline.
No, that's a very, we no longer use aminophylline. You've never seen a small machine and somebody gets a mask on their face?
Oh, nebulizer.
They're nebulized, right? Yeah, they're nebula. And what is in that solution?
Salbutamol.
Yeah, it can be salbutamol or it can be a combination of salbutamol and ipratropium, right?
Yeah, so tabutaline.
Yes. So because you want to oppose the functions of acetylcholine in the bronchus. Okay? Now in the secretory glands, what happens when you're scared? Do you usually have do you feel if you get some bad news, okay? What happens to your appetite?